Welcome to Falcon Physician Reviews. This section is endocrine pathology. This section will include pancreatic pathology, diabetes, as well as islet cell tumors. We'll start with diabetes mellitus. Diabetes mellitus is a chronic systemic disease of carbohydrate, fat, and protein metabolism. It can result from one of two primary mechanisms. Type 1 diabetes results from impaired secretion of insulin, and we'll talk more about this in a moment. Type 2 diabetes primarily results from target tissue insensitivity to insulin. Clinical diagnosis is based on hyperglycemia. There are several ways to diagnose diabetes. A fasting serum glucose of 126 milligrams per deciliter or greater on two separate occasions is diagnostic of diabetes. Additionally, a random serum glucose of greater than 200 milligrams per deciliter in the presence of symptoms of diabetes, which would include polyuria, polyphagia, is also diagnostic of diabetes. Additionally, a positive oral glucose tolerance test. Now, an oral glucose tolerance test is rarely used these days, but that is a third way of diagnosing diabetes, and we'll talk more about the specifics of that test in a few minutes. How do you classify diabetes? Type 1 diabetes, the pathogenesis of which we'll discuss more shortly, is an autoimmune condition characterized by destruction of islet beta cells, resulting in reduced insulin secretion. Type 2 diabetes is another form of diabetes characterized by tissue insensitivity to circulating insulin. There are a variety of other types of diabetes which do not fit into type 1 or type 2 categories. Some of these, briefly: genetic defects of insulin secretion, for example, maturity onset diabetes of youth. Other examples: leprechaunism is a genetic defect of insulin actions. Diseases of the exocrine pancreas, for example, hemochromatosis, chronic pancreatitis, status post a Whipple surgery. These are yet other causes of diabetes. A variety of endocrinopathies, for example, growth hormone secreting tumors, Cushing's syndrome, glucagonoma, all of these endocrinopathies can also cause diabetes. Congenital rubella infections are a rare cause. Iatrogenic, for example, medications, primarily glucocorticoids, can cause diabetes. And then there are some very uncommon forms of autoimmune diabetes, for example, stiff man syndrome and a condition associated with anti-insulin receptor antibodies. As far as genetic syndromes, Down syndrome is one of the more common congenital syndromes associated with diabetes. Gestational diabetes is a fourth category of classification of diabetes. Then there are some so-called pre-diabetes high-risk categories. These conditions are not technically classified as diabetes, but these patients are considered at very high risk for progressing to full-blown diabetes. One is characterized by impaired fasting glucose. The second is characterized by impaired glucose tolerance. So impaired fasting glucose, in this setting, a patient would not meet criteria for full-blown diabetes. For example, the blood glucose would not be greater than 126, but it might be above 110, between 110 and 126. That would be classified as impaired fasting glucose. Impaired glucose tolerance would be a glucose greater than 140 but less than 200 on an oral glucose tolerance test. These patients, as stated previously, are at increased risk for progressing to full-blown diabetes if interventions such as lifestyle modifications, exercise, and diet are not undertaken. So some more about type 1 diabetes. Basic characteristics. Classically, for boards, the patient will be young, usually less than 20 years of age. The weight is usually normal or thin, but these patients are typically not obese. Genetic predisposition, there is a strong concordance in twins. Having said that, type 1 diabetes does not strongly run in families. Type 1 diabetes is also HLA linked, especially HLA-DQ, but also HLA-DR3 and 4. As we said earlier, the pathophysiology involves an autoimmune destruction of the beta cells. So antibodies are produced to a variety of antigens in the islet beta cells, and the beta cells are selectively destroyed in type 1 diabetes mellitus. It's unclear why this happens. There are a variety of theories. One of the more common theories is that there is a viral infection early on in life that predisposes to destruction, to autoimmune destruction of the beta cells. Type 1 diabetes is characterized by carbohydrate intolerance with hyperglycemia. The clinical presentation of these patients, they may present with polyuria, they may present with polyphagia, they may present with diabetic ketoacidosis. So we'll talk more about these symptoms in a few slides. But briefly, polyuria, of course, is frequent urination. Part of the reason for that with hyperglycemia is the glucose delivered to the kidneys is more than the kidneys can reabsorb, and so there's loss of glucose in the urine as well as electrolytes. That creates an osmotic diuresis and causes polyuria. It also causes these patients to be dehydrated commonly. Polyphagia is increased appetite. So diabetes, type 1 diabetes mellitus is interesting in the sense that these patients will often have a preserved or quite a good appetite, but simultaneously will have unintentional weight loss. And there's only a few conditions in medicine that are associated with unintentional weight loss and preserved appetite. Those conditions, in addition to type 1 diabetes mellitus, would include hyperthyroidism and various malabsorption syndromes, but certainly not malignancy. Classically, malignancy is characterized by anorexia, night sweats, and fatigue. So hyperthyroidism, diabetes mellitus, and malabsorption syndromes are the ones you think about with preserved appetite and unintentional weight loss. Pathologically, there's an insulitis, so there's inflammation of the islet cells. When you do a biopsy or an autopsy, you will see a proliferation and an invasion of inflammatory cells in the islet. Moving on to type 2 diabetes mellitus. Characteristically, type 2 diabetes mellitus occurs in older adults. Now, this is a changing epidemiology. If 10 or 20 years ago, classically, older adults who are sedentary and obese would present with type 2 diabetes. Nowadays, unfortunately, with the obesity epidemic, this is becoming increasingly common in young children, even, and teenagers. So this is a rough rule of thumb that it's at later onset than type 1, but commonly we will see young individuals with obesity diagnosed with type 2 diabetes. In contrast to type 1 diabetes, there is often a strong family history of type 2 diabetes. Now, the pathophysiology of type 2 diabetes mellitus is very interesting. Initially, there is hyperinsulinemia. So early on in type 2 diabetes, there's clearly no dysfunction of the beta cells. In fact, they're hyperfunctional. They're hypersecreting insulin. And the main pathogenesis in the early stage is that these patients are resistant to insulin, partly because they may be obese, partly because they may have a sedentary lifestyle, and additional reasons are as of yet unclear. So early on in the disease, these patients will have elevated levels of insulin and C-peptide if you were to measure them. Later on in the disease, many years later, you can get this phenomena of beta cell burnout. And if you were to measure C-peptide and insulin levels at this time, you would actually find, similar to type 1 diabetes, that they're low. So it can be challenging occasionally to differentiate between type 1 and type 2 diabetes mellitus. Complications of type 2 diabetes mellitus, ketoacidosis is rare. Ketoacidosis is relatively common in poorly controlled type 1 diabetes, but because there's always some amount of insulin production in type 2 diabetes mellitus by the beta cells, generally speaking, these patients do not get ketoacidosis. I should point out, though, that type 2 diabetics can get ketoacidosis under significant stressors. So if they have a raging infection or sepsis or pancreatitis or are undergoing a major surgery, they can get diabetic ketoacidosis. Another complication they can get, as opposed to ketoacidosis, they can get hyperosmolar non-ketotic coma. This was recently renamed hyperosmolar hyperglycemic state, and we'll talk about that a little later. Pathology, you get fibrosis and hyalinization, sometimes referred to as amylin deposition in the beta cells. Gestational diabetes. This is an asymptomatic glucose intolerance which is detected during pregnancy. Typically, screening is done between the 24th and 28th weeks of gestation. There's a 1-hour post-glucose challenge. In this case, they use 50 grams of glucose. And if the serum glucose is greater than 140 milligrams per deciliter, it's a positive test, implying that the patient has gestational diabetes. This is quite a common disorder. It affects approximately 15% of pregnant women. The risk factors for gestational diabetes include obesity, age greater than 35, positive family history of diabetes, and a prior large baby. So if the woman has delivered a baby that's been greater than 9 pounds in size, that's a risk factor for gestational diabetes. What are the complications of gestational diabetes? For starters, gestational diabetes can predispose the mother to the non-gestational form of diabetes later on in life. So this is quite significant. Approximately 50% of women with gestational diabetes will develop full-blown type 2 diabetes mellitus within the following 15 years. Other complications include increased birth weight and, unfortunately, an increased frequency of congenital malformations. Additionally, the infant can be born with hypoglycemia. To make sense of this, you have to realize that a woman with gestational diabetes has elevated levels of blood sugar. Now, sugar can cross the placental barrier, so the fetus is exposed to elevated levels of blood sugar. So the fetus, the pancreatic beta cells are hypersecreting insulin in the fetus. This is fine during pregnancy, but once the baby is delivered, they're no longer exposed to elevated levels of glucose, but they are still secreting large amounts of insulin. And so you can see how this can lead to hypoglycemia. It also explains the large birth weight size. The fetus is exposed to large amounts of sugar, therefore the pancreas secretes excess amounts of insulin, and insulin has well-known anabolic actions, and so you have a large-sized baby. So complications of diabetes, the pathogenesis of these complications is somewhat poorly understood. There are two fairly prominent theories to try to explain this, but there's still many questions remaining. The first of these involves the production of advanced glycosylation end products. The second theory involves acceleration of the polyol pathway, resulting in protein kinase C activation. So advanced glycosylation end products are essentially chemical products that are formed by glycosylation, nonspecific glycosylation of various proteins, particularly long-lived proteins like collagen and elastin. And what happens is glycosylation, nonspecific glycosylation of these proteins results in cross-linking of the polypeptide strands, and this alters the tertiary conformation of the protein. It may change the functionality of the protein, and perhaps more importantly, it may decrease the ability of these long-lived proteins to be degraded. Let me give you some examples. In the example of LDL and atherogenesis, normal LDL, which is not glycosylated, is less susceptible to oxidative damage and atherogenesis than glycosylated LDL. So in the presence of hyperglycemia, LDL can be glycosylated. It is then more susceptible to oxidative damage, and as is well known, oxidized LDL can then deposit in the arterial wall and predispose to atherosclerosis. The polyol pathway is a pathway that is accelerated in chronic diabetes and hyperglycemia. As glucose enters the cell, it increases the aldose reductase pathway, and glucose is converted into intracellular sorbitol and fructose. This can create osmotic cell injury, and you get increased production of diacylglycerol formation. Increased diacylglycerol formation stimulates the protein kinase C pathway, and protein kinase C stimulates a variety of transcription factors that activates genes thought to be involved in some of the pathogenesis of diabetes complications. So those are the two prominent theories. Diabetic ketoacidosis is something primarily seen in type 1 diabetes, although as mentioned you can occasionally see it in type 2 diabetes. Diabetes ketoacidosis occurs in the absence of insulin, and what happens is you essentially get what some people refer to as runaway lipolysis in adipose tissue. So in the absence of insulin, lipids are degraded in adipose tissue, and there's the free fatty acids and glycerol are shunted to the liver, and you then get substantial hepatic ketogenesis. So you get the production of these ketone bodies. For example, beta-hydroxybutyric acid, acetoacetic acid, and small amounts of acetone. This explains the kind of fruity odor on the breath of patients presenting in DKA. So hepatic ketogenesis is really the hallmark of DKA. Hepatic ketogenesis explains a lot of the signs and symptoms seen in diabetic ketoacidosis. For starters, it explains the significant acidosis, because ketone bodies are acids. It explains the metabolic acidosis actually can cause what is known as Kussmaul respiration. So these patients typically come in with rapid, deep breathing. And the reason for that, with any severe metabolic acidosis, the lungs will try to compensate by blowing off excess CO2. So that is known as Kussmaul respiration. I already mentioned that they may have a fruity odor to their breath. The physician may mistakenly think they've been drinking alcohol, but this is a classic sign of DKA. They may have abdominal pain due to the acidosis. Other classic features of the presentation of DKA, these patients can be extremely hypovolemic. Now, they have an osmotic diuresis for several days, which predisposes them to hypovolemia. They're also potassium depleted. Now, this is interesting. This is total body potassium depletion. So, in fact, when they present to the emergency room or the clinic, they may be hyperkalemic. So, because they have a metabolic acidosis, there's a shift. Potassium, you will recall, the vast majority of potassium is intracellular in origin. In the presence of an acidosis, protons come into the cells from the blood and the interstitium, and in exchange for potassium ions. So in fact, what's happening in the presence of an ongoing osmotic diuresis, the body is being leached of its intracellular stores of potassium. At the same time, however, the plasma potassium may be elevated. So these patients can mistakenly be treated for hyperkalemia when in fact their total body potassium depleted. In fact, Once fluids are given and their potassium comes down ever so slightly, you need to give these patients more potassium. As mentioned, they can have an acidosis and Kussmaul respiration. We already mentioned the abdominal pain. How do you treat these patients? There's a variety of fancy ways to treat them, but in the end, they need fluids, and more fluids. These patients are phenomenally volume depleted. When you correct the dehydration, to a certain extent, you correct the hyperglycemia and the acidosis. Occasionally, you will need to give them small to moderate amounts of insulin. There's rarely a requirement for large amounts of insulin. As mentioned, they may be hyperkalemic, but they're still total body potassium depleted, so you may need to give them potassium. You don't want to drop the glucose down too quickly because of a concern for cerebral edema. But once the sugar approaches 200 or 250 or thereabouts, you'll want to think about starting some dextrose so that the glucose doesn't precipitously drop further. Bicarbonate is, as always, it's controversial. If the acidosis is relatively mild, bicarbonate is generally not needed. If it's a severe acidosis where the pH is 7.1 or less, some physicians will use bicarbonate. Another complication of diabetes is hyperosmolar hyperglycemic non-ketotic coma. Now, this is really a misnomer, and fortunately a few years ago it was renamed hyperosmolar hyperglycemic state. The reason it's a bit of a misnomer is these patients typically do have some amount of ketosis, so they will have a mild ketoacidosis. It's just not near as severe as in DKA. Additionally, it's relatively rare for these patients to present with coma. They may present with altered mental status, some confusion, but it's relatively rare. Perhaps 5 or 10% of patients will actually present with a coma. The pathogenesis of this, these patients are in fact even more volume depleted than DKA patients, and this is because the process has been going on for a longer period of time. So they really have a prolonged osmotic diuresis, which causes severe dehydration. As the name implies, it's characterized by severe hyperosmolarity. So a typical plasma osmolarity would range from 280 or thereabouts to 300. So in this case, you would have an osmolarity of greater than 320 milliosmoles per liter. It's also characterized by severe hyperglycemia, greater than 600 milligrams or so per deciliter. Treatment is very similar to DKA, fluids, and fluids. You may, like DKA, give some moderate amounts of insulin, moderate amounts of potassium. Rarely is bicarbonate needed. In terms of vascular complications, diabetes is typically thought of as causing microvascular disease as well as macrovascular disease. Microvascular disease causes retinal pathology, renal pathology, and damage to the nerves. So retinopathy, nephropathy, and neuropathy. Macrovascular disease, we think of diabetes as accelerating or predisposing to myocardial infarction as well as peripheral vascular disease. In terms of microvascular disease, the classic type 2 diabetic may have a neuropathy where they can't feel their feet too well, and so what happens is they may injure their foot, or they may have an ulcer on their foot, a pressure ulcer, and they don't realize. And then because they have vascular disease as well, the ulcer or the wound doesn't heal well, and then ultimately it may become infected. And this is kind of how type 2 diabetics are predisposed to distal extremity infections, and ultimately, unfortunately, may lead to below the knee amputation in poorly controlled diabetes. So this is a serious issue. The retinopathy is something that can really be thought of by clinicians as a warning sign. Typically it happens before diabetes is actually diagnosed, and once diabetes is diagnosed, these patients really should be followed by an ophthalmologist on at least an annual basis. As far as nephropathy, there are glomerular lesions and tubular lesions. In the glomerulus, you have one of the earliest and most common changes is capillary basement membrane thickening. And you get these characteristic Kimmelstein-Wilson nodules, which students should know for the boards. There are also tubular lesions, the Armani-Epstein lesion, and in this case, hyperglycemia results in tubular deposition of glycogen. Other renal lesions, diabetics can get a type 4 hyporeninemic, hypoaldosteronemic metabolic acidosis with hyperkalemia. Other diabetic complications, diabetic ocular complications include the retinopathy we discussed, but this is a proliferative retinopathy. And what happens actually is there's areas, because of the vasculopathy, there are areas of ischemia to the retina, which induces the release of growth factors such as vascular endothelial growth factor. And what happens in response to the ischemia is really a uncontrolled proliferation of new blood vessels. And these new blood vessels can impair vision. So this is termed a proliferative retinopathy. It also predisposes to cataract formation, and so you have these long-lived crystalline lens proteins in the lens, and as I mentioned earlier, the advanced glycosylation end products occurs with long-lived proteins, and this can predispose to cataracts in diabetics. In terms of the diabetic neuropathy, you can get a peripheral neuropathy. You can get orthostatic hypotension, so that's interesting. The diabetics, the baroreceptor reflex may not work quite as well as in non-diabetics. And so when they stand up, because the baroreceptor reflex is not working well, they may have some symptoms of orthostatic hypotension. Diabetics can also get a neurogenic bladder. This concludes the session.